Uh,
Good morning, sir.
okay. Dr. Virul, your slide is ready now?
Yes, sir. Yes, sir. Yes, sir.
Okay, good morning. Good morning. Today we'll have a discussion on a case on soft tissue sarcoma represented by Dr. Behrul Huda, who is a second year junior resident at South Eastern Gardenich Hospital, and will be faculty Dr. Somita Chatterjee, who is a professor of surgery at IPGM SKM Hospital. So Behrul, you can share your screen and wait at the end of history and then discuss some point in history and then proceed to examination and subsequent discussion. Okay?
Okay, sir. Okay, sir.
Okay.
Yes, Behrul, your slides are visible. You can start.
Good morning, everyone. Myself, Dr. Behrul Huda from South Eastern Central Rural Hospital, and I am going to present a case of soft tissue sarcoma of left lower limb. So, a 45-year-old patient named Ajit Mahato, by occupation senior technician, resident of Chakardarpur, presented with chief complaint of swelling in the left leg since last 7 months and pain over the swelling since last 3 months. So, history of present illness. The patient was apparently well 7 months ago. Then he noticed a swelling in the left leg in the upper one third of the lateral aspect of the left leg, which was insidious in onset, initially smaller in size when noticed by patient, approx 2 into 4 centimeter in size, which rapidly increases the size of 10 into 7 centimeter over the period of last 1 month, and there is no any other swelling in any other part of the body. Patient also complains of pain for last 2 months in the swelling area, which was insidious in onset and mild in nature, and it is not radiating to any other area. There is no history of any swelling in the groin region, any abdominal pain, or any swelling in the abdomen. There is no history of jaundice, cough, hemoptysis, or there is no any neurological symptoms as such. Patient has been recently diagnosed as a case of hypertension, for which he is an oral medication. In a family history, there is no similar history in the family, or there is no any other similar carcinoma history in the family. Personal and social history. Patient is married, has one child, and with both child and wife are healthy. There is bladder, bowel, sleep is normal. Their appetite is mildly reduced, and he takes mixed Indian non-veg diet. There is no addiction present, and he belongs to average socioeconomic class. Yes, sir. History is complete, sir.
Okay, Behrul, can we go back to your first slide, please?
Yes, ma'am.
Yeah. This is not only for you, this is for everybody. Whenever you present a history, avoid mentioning the patient's name, because we should, honor the identity of the patient and not disclose the identity. Okay, so Mr. X or whatever you like to say, or a 45-year-old gentleman, avoid using the patient's name when you're presenting something, because I'm sure you'll be using a clinical picture subsequently. So it is better to preserve the identity of the patient. Okay?
Yes, ma'am. Yes, ma'am.
Can we move to the next slide, please?
Yes, ma'am.
Yeah, can you move to the next slide? Yes. So you said swelling in the left leg since last 7 months, and there has been a rapid growth in the swelling. I think that is mentioned here. Yeah, so can you switch to the next slide? Yeah. So if you say that there has been a rapid growth in the swelling, what is the first idea that you are getting? 1 month from 2 centimeter to 10 centimeter. That is a really rapid growth. So what is the thought in your mind? Just from the history, you've not yet examined the patient clinically.
Most likely a malignant tumor.
It is most likely a malignant tumor. Okay. The subsequent history that you gave, that there is a pain in the swelling. So
yes, ma'am.
Normally these swellings in the limb, are they painful?
Yes, ma'am. Yes, ma'am.
Are they painful?
No, usually they are not painful. They are painless.
Okay, so you said that your patient does have pain, although it is mild, you have mentioned. So if
Yes,
a patient does have pain, what is the cause of this pain?
it might be that neurovascular bundle has been involved.
Neurovascular bundle. If neurovascular bundle is involved, only pain will not be the point. There'll be
Also,
something
there
more,
will be stretching of the
right?
deep fascia. Stretching of the deep fascia and skin can also causes pain.
So it is, if there is a rapid growth, the commonest thing is a stretching pain.
Yes, ma'am.
The neurovascular involvement comes much later.
Yes,
Okay,
ma'am.
so the pain due to a nerve issue
Yes.
is going to be the second point. Your first point is because there's been such a rapid growth, 2 to 10 in a month, that it
Yes,
is a rapidly expanding and therefore a stretching pain. Okay,
Yes,
can we
ma'am.
move to the next slide, please?
This one, regarding the swelling,
Yes, sir.
Behrul,
Yes, sir.
this is a virtual case, I agree. But
Yes,
you will
sir.
find most of the soft tissue sarcomas in the extremities, they doesn't start as benign and then turn to malignant. They are malignant
Malignant
de
to begin
novo.
with, yes.
Yes. So
Yes.
this history, you are putting at virtual history. That's why you are putting like this. This is not the usual history for a soft tissue sarcoma involved in the limbs. They are
Yes, sir.
starting as sarcoma and growing as sarcoma, but the behavior may be different. It may be
Yes.
that some soft tissue sarcomas can grow slowly,
Yes, sir.
some may grow rapidly. So it is very unlikely that 6 months it was static and then 1 month time it become tension. See, it's not because patient will be in front of you. When you are applying the examination, it's not
Yes,
a
sir.
virtual case. Patient
Yes,
in
sir.
front of you. So examiner might ask. So in that
Yes.
case, it is not necessary to corroborate that it was a benign and then turn to malignant. These are not the behavior of soft tissue sarcomas. And
Yes,
second
sir.
is go to the pain. Madam was asking you what is the cause of the pain. Next
Yes.
slide. You see, one you said as the swelling is going rapidly, that means
Yes.
stretching pain. And you
Yes.
said there might be more neurovascular bundle.
Yes, sir.
So what will be the difference of pain? You see, the two things. One pain is because of stretching, and another pain is because of infiltration of the nerve
Yes, sir.
underneath.
Yes, sir.
So will the pain be same in two situations or pain will be different?
Pain will be
The
different,
pain
sir.
you describe is a
Yes.
mild pain, no radiation,
Yes, sir.
and often this pain may be relieved with a mild analgesics. And what
Yes.
about the pain which is because of nerve infiltration?
That will not relieve with taking medications, and there will be
No,
hyperesthesia.
not before medication. Before medication, you
So
see,
what is the nature of the
a
pain?
nerve getting compressed or nerve being infiltrated, it's a neural pain.
Yes,
And
sir.
that pain has got a pain
Characteristic.
distribution along the segment of the nerve.
Yes, sir.
That pain, if the nerve is infiltrated, will be a continuous, constant pain
Yes, sir.
and difficult to be relieved with simple analgesics because you have to give an explanation for this pain. The pain because of stretching, maybe mild aching, dull aching pain, may not be continuous all the time, maybe
Yes.
relieved with mild analgesics. But nerve distribution pain will be something which is because of nerve compression or nerve infiltration. That
Yes.
once nerve is infiltrated, you try to understand. If the nerve is infiltrated,
Yes,
it's
sir.
unlikely the patient will have pain unless the nerve is getting relieved of this compression or infiltration. Okay, so we have to describe the pain in that sense. Next,
Also,
Yes.
there is going to be a radiation of the pain if there is
yeah,
the pain is due to a nerve problem.
yeah, along the distribution of that nerve, or there might be a referred pain out of
Referred
this.
pain somewhere, yes.
Yeah.
Yes.
Can you move on to the slide on family history and other things?
Yeah, yeah.
Yeah.
You see, if you say he recently diagnosed hypertension, he didn't go to past history. That easily
This
go
is
to
a
the history of present illness.
yeah.
If he is
So-
hypertensive for 10 years, yes, patient is a known hypertensive. If recent diagnosed hypertension means this is within very much within your history of present illness. What in past history is important?
Sir,
Patient
there
has
is,
got a sarcoma suspected.
yes,
Anything
sir.
in the past history is important.
Any past history of radiation or trauma to the limb?
yes.
Yeah.
Not just a one-time trauma, some chronic trauma. Some
Chronic trauma.
pre-existing, yes.
Yes, ma'am.
I would like you to go to that slide where you had the personal habits and family history. So you said no history in the family. Is limb swelling like this, can it be of familial origin?
In the cases of Lee-Framonis syndrome,
Yes. Or something else?
In retinoblastoma.
Retinoblastoma in the leg.
If there is involvement of retinoblastoma one gene, then this occurs in.
What other genetic background?
about
One is leaf-formining, P53 suppression gene mutation. Another is you asked about other swellings in the body. Patient may have multiple
Neurofibromas. Yes.
but may have other swellings in the body. So no history of stigmata of neurofibrosis in the family.
Yes, sir.
What sort of sarcomas occur in patient with neurofibromatosis?
Fibrous hysteria.
Huh?
Fibrous hysteria.
Fibrous. Patient having neurofibromatosis.
So neurofibrosarcoma.
Yes, sir. Yes, sir. Neurofibrosarcoma. Sorry, sir.
Neurofibrosarcoma.
Or malignant nerve sheath tumor.
Nerve sheath.
Yes, sir.
Okay. You had said about, can you go back one more slide, please?
Yes, ma'am.
One more slide. Yeah. No, not this one. Where you had said that the patient has an appetite which is reduced. Do you think this swelling will lead to
personal history?
Personal history.
Personal
Right.
history.
Yeah.
Personal history.
You said that since you will be a postgraduate student for your MS or DNB, things like has one child, both child and wife are healthy. These are not relevant at this level, and MBBS is fine. Bladder, bowel, sleep is normal. Appetite is reduced. Do you think this swelling in the limb can lead to a reduction in appetite? It is not any other malignancy. And if the patient is having a reduced appetite, would you like to think about anything else?
If there is a reduced appetite, I think this case will shift to malignant with metastatic case.
Okay, so we are already thinking as malignant because of the rapid growth of the tumor. So otherwise, if the swelling is localized to the limb, it is unlikely that he is going to have a reduction in appetite, loss in weight, and all the things we associated with other malignancies. But if your patient does have it, you have to keep in mind that there may be a metastatic spread. And when you examine the patient and work up the patient, that has to be kept in mind.
Yes, ma'am.
Okay. Sir, shall we move to the clinical examination, sir?
Occupational history, anything?
Yeah, occupational.
He was
any occupational history which has higher incidence of sarcomas?
In people using in working in chemical industries, like where there is a use of arsenic or
Yes.
Yeah.
Yes, sir.
Okay. They just mention his occupation, what he is on. That's it.
Sir, he's a senior technician in sir. He's a senior technician in railways, sir.
No.
Yes.
Okay.
Examination, please.
Yes, ma'am. So I have examined the patient after taking proper consent in well-lit room, and patient at the time of examination was alert, conscious, cooperative, and oriented to time, place, and person with ECOG score of 1. There is a decubitus of choice was present. Face is normal. Gait should be a light antalgic gait was present. Patient is average build, height of 175 centimeter, weight 65 centimeter, 65 kg, BMI of 21.22.
Just mention BMI. That's it. Why do you write again weight, height? Just mention BMI. That's it.
Yes, sir. BMI of 21.22 kg per meter square. Hydration was adequate. Nutrition average. There was no pallor, cyanosis, clubbing, jaundice, or edema. Having a pulse rate of 86 per minute. BP 136 by 88 millimeter of mercury, and respiratory is 16 per minute. On temperature was normal. There was no engorged veins, no any obvious deformity. There was no any pigmentation on the skin. On local examination.
Just wait. Can you go back once again?
Yes,
see, in your general survey, there were two things that I would have liked to know. You had said that the patient has a decubitus choice, which I understand. What about the orientation of the limb? If you say that I'll mention it in my local examination, that is fine. But whenever you have an extremity swelling, particularly the lower limb, what is the orientation of the limb? Is it normally oriented? Or, is the limb distorted? That has to be mentioned. When you're talking about temperature, are you talking about the systemic temperature or are you talking about the local temperature?
Systemic temperature.
Systemic. So exactly. So mention that, because in this case, the patient may be, obviously systemic temperature may be normal, but when you do a local examination, there may be a rise up. So when you just say temperature, you leave it to two more questions. So say that
and then how to say it's normal, temperature normal? with your back of the fingers?
Now, on general examination,
No. You say temperature is normal.
yes, sir.
How did you comment about that?
So the patient was having a normal temperature.
No. Patient said he has no fever, but once you are writing in general survey, temperature
Yes.
normal, what
Yes.
you have documented?
So using a
Keep
thermometer.
in mind that this should be measured by thermometer.
Thermometer.
Yes,
If
sir,
you
using
don't
a
have a thermometer, right, temperature is not recorded. Don't say that I examined with my back of fingers and find patient is febrile. No.
Oh,
If
sir,
your madam is asking, is temperature
Yes.
is what? Temperature of the local site or temperature as a, in the body core body temperature? So core
Yes.
body, if you say normal, it has to be measured by a thermometer.
Yes, sir.
Okay.
Okay.
Please carry on.
Okay.
Local
Local
examination.
On inspection, swelling, there's a swelling in the left leg in the upper 1/3 of the lateral aspect of left.
Again, you are starting with the swelling. That's what I'm trying to say. When you
Think
are
of the
examining,
limb
she has
as a
got a
whole.
swelling in the leg. It should be examination of both lower limbs.
Yes.
It does not start with the swelling straight away. Try to
Yes.
understand. Patient has a swelling in the leg. Your idea
Yes.
is to examine the leg. So how do you start? If you start with examining the leg, how do you start? He might be standing in front of you, or he might be in the bed.
Now I'll start the examination by keeping the patient in a standing position and by
Fine.
by
And how do you
looking at
start? I don't start with the swelling.
Do you
Yeah.
not look at the normal
At
limb and comment on it?
attitude. I'll start by
Yes.
looking at attitude and the attitude of the both the limbs
Attitude and any deformity.
and
Attitude
deformity.
and deformity. That is the first thing you should say. Swelling
sir.
comes next.
Much later.
When you are standing, patient
Yes.
might have some deformity in the leg already. Okay, sir, comment about the attitude. What is the normal attitude of the limb? If he's standing in front of you, when do you say patient has got a normal attitude of the limb? I mean to specify the ankle, knee, hip. At what position you will say, yes, this patient is standing in front of me and he has got a normal attitude of the limb. What is that attitude?
Sir, when the knee joint is near to both the knee joints are lying in near to each other and there is no any
Knee joint is straight. Knee joint is
Okay.
straight. What about the ankle?
there is no any deformities in the ankle. The
Ankle remains at what angle? If you are standing, at what angle ankle remains?
45 sorry 90 degree
45. It's 90.
with the originator.
Ankle 90 degree. Knee straight. Hip.
Yes.
Hip straight.
Yes, sir.
So if you're standing with the legs side by side, you will find that both the limbs will have the same attitude.
Yes, sir.
So start with that. Attitude of the limb is normal. Any deformity, patient might have some, you said nerve compression or whatever, patient might have some deformity, flexion deformity in the leg or some deformity in the form of toes, whatever. So no deformity. Then you can come to swelling and then muscle wasting go later on. That is okay. Okay, so keep in mind for any, even in a venous examination, arterial examination, it starts with examination of the leg as a whole, not with the straight vein or the artery or the swelling itself.
Yes.
Fine, now come to the swelling.
Yes.
Behrul, just one more point. See, whenever you have an extremity swelling, be it the upper limb or the lower limb, or any bilateral organ, say a breast also. See, always start off by saying that in this case, yours is a left leg patient, that the right leg is normal, because otherwise you are going to forget to examine it by the time you finish your affected leg. So the right lower limb is normal. Then, as sir said, left lower limb, the attitude, the deformity, and then you go on for the local examination.
Yes.
Please continue.
So on examination, the attitude, the attitude of the limb was within normal limit. The knee joint was straight, and the ankle joint was lying 90 degree with the.
You have
normal
a
attitude
thigh.
is understood.
Yes, sir.
So you have a thigh swelling. So it is not only knee and ankle. You have to remember the hip as well.
Yes,
right?
ma'am.
So
Yes,
one joint above, one joint below. That is what we always recommend. So it is, you have to, don't forget the hip. The position of the hip is also important.
Yes.
Okay,
So
please continue.
on inspection, the right leg was essentially within normal limit, and in the left leg, there was a swelling in the upper 1/3 of the lateral aspect of left leg, which was irregular in shape, with having smooth surface, well-defined margin, and the skin over the swelling was normal. There's no any other swelling present in that leg or in that vicinity. There was no visible scars. There was no there was a mild restriction of limb movement.
Okay, we'll stop there. We'll stop there. Just go back. Go
Yes,
back.
ma'am.
One slide back. Yeah. So you said that it is irregular in shape but smooth surface. But you had said and well-defined margin. You had said it was a very rapidly growing mass, and within 1 month it had jumped from 2 centimeter to 10 centimeter.
Yes,
Do
ma'am.
you expect a smooth surfaced, well-defined margin swelling in such a rapidly growing mass?
Again, it's a virtual case. You prepared
Yeah,
it.
I
You
understand.
prepared it. But you'll
Yeah.
find most of the patient having soft tissue sarcomas,
Yes, sir.
they grow in a fascial compartment.
Yes, sir.
And from the surface, most of the time it is a smooth surface.
Yes, sir.
Unless it is a very large tumor, you can find nodules on the surface. Most of the time it's a smooth surface.
Yes, sir.
And you can find the margins are also not that irregular. So you prepared a virtual case, so you try to make out as a malignant mass. But in examination, most of the time you find is not like that.
Even in a virtual case, if you said that it is a very rapidly growing tumor, in rapidly growing tumor, the margins are not so well defined. Okay. And
Yes,
then
ma'am.
such a rapidly growing tumor will, unlikely to have a smooth surface, will probably have a bosselated surface. So if you write in your history that it is rapidly growing, you should incorporate findings associated with rapidly growing. Otherwise, this is classical of a
Patient who
soft
is in
tissue.
front of you.
Yeah. So
You
you're
have to
saying,
make out a
yes,
good
yeah.
examination and find what is there in front of you. So we are doing virtual, that's okay. But everything depends on your skill of examining a patient in real time.
And
Yes.
correlating it with the history.
Yeah.
Yes.
Okay.
Yes, ma'am.
Again, normal skin over the swelling. What would you look for? Here the skin is normal. What could be the changes in the skin in such a patient?
There will
The
be
swelling is increasing rapidly in size.
Yeah.
there will be thinning of that area of the skin with venous prominence will be present.
Yes. So the shiny skin. Shiny skin with prominent veins.
Yes,
You've
ma'am.
talked about visible scars. What scars are you thinking of?
If this was a case of recurrence, then previous surgery scar might be present.
Okay.
Or if there is any history of taking biopsy from that lesion, already scar will be present.
Correct.
And there is no history of trauma. So if there was a history of trauma, so the scars might be present in cases of trauma. Yes,
okay. So when you had said about restrictions,
what area?
Sorry, sir. Please go ahead, sir.
Yeah. I'm not sure what you are trying to put the swelling in the leg, where in the thigh, below the knee, in the calf region, where it is. You are all the time trying to say left
he has
leg.
mentioned in the upper third of the lateral aspect of the leg. Upper one third,
of
lateral
leg
aspect,
what?
leg.
You want to
leg
say thigh?
Below the knee joint,
There's no
sir.
picture. Huh?
Below the knee joint, sir. In the leg.
Because the term leg is used as area below the knee joint.
Yes, sir.
That is a loose term for leg. And thigh is the upper part of the leg. So that's why I'm wondering.
Yes,
I was not sure what I'm trying to describe. It is below the knee joint.
Yes,
in the calf region, you mean?
Yes, sir. Yes, sir.
Okay. So on the upper third of the lateral of the leg below the knee joint.
Excuse me, sir.
Yes.
Leg means you wanted to mean the area below the knee joint.
Yes, sir. Yes, sir. Below the knee joint, sir.
Okay. Another thing you said, no restriction of limb movement. Again, no restriction meaning where? At the hip, at the knee, or the ankle. That has to be mentioned. Restriction of when you check for restriction movement, it has to be one joint above, one joint below, as we said. So if there is no restriction, please specify which joints you've examined. Okay. But you're still at inspection. This is usually done later. Okay. So please continue.
On palpation, there was a mildly raised temperature from the surrounding area over the swelling. There was a mild tenderness present. And on palpation, the shape was irregular with smooth surface, margins regular. The tumor was firm in consistency and it's not freely mobile. It is fixed to the underlying muscle, and skin over the swelling was normal. There was no visible pulsations or palpable pulsation present. And pulse residual the swelling was present. There was no inguinal lymph node palpable. There are no neural lymph nodes palpable.
Okay,
And,
come back again. Come back, please. Right.
Yes.
So you've said there's a temperature was mildly raised. Now, in these patients, these soft tissue sarcomas, what is the cause of this rise in temperature?
Highly vascular tumors and rapid growth.
Yes, so it is usually the highly vascular. It is not that it's a local inflammation or something which is causing the rise in temperature.
Yes, ma'am.
Highly vascular tumor. Tenderness is not a very obvious finding. Again, as you said, if it is a rapidly rising temperature, rapidly rising growth, otherwise tenderness is not a usual feature. Irregular in shape, smooth surface, forming. Not freely mobile, fixed to underlying muscle. How did you check for this fixity to the underlying muscle in the lateral part of the leg?
What muscle is deep to the swelling? Anatomically, you are examining the patient, you are shown the picture. What muscles are there deep to the swelling?
Hello, sir. So your sound is not. Hello, sir.
What muscles are there deep to the swelling site? You have to test for that muscle. Na?
Tibialis anterior and tibialis anterior extensor group of muscles are also present. And
so it is more towards the lateral compartment of the leg you want to mean?
Yes, sir. Lateral
Yes.
spectrum.
Okay. Then how did you test for this?
Then
Just tell
peroneus
us,
longus.
how
and
have you tested for the muscle fixity? Clinical method.
Yes, sir. We'll taut the muscle and then we'll move the.
No.
How did you
No,
make it
we will not
taut?
taut the muscle.
First,
No.
what will you do?
Yes, ma'am.
What is the first step?
Don't
Right
taut the
away, you
muscle
do not
first.
taut the muscle. What is the first step? With the muscle relaxed, you move the lump in
Yes,
both
ma'am.
axes. Now,
Yes, ma'am.
obviously,
Yes,
the vertical axis, you don't expect it to be mobile. It is more in the horizontal axis.
Horizontal axis.
Next is you are going to taut the muscle and recheck for whether there is any restriction in movement of the swelling.
Yes,
Now,
ma'am.
lateral aspect of the leg, how will you taut the muscle?
The eversion of the ankle joint.
Eversion
Yes,
of the
ma'am.
ankle joint. What is the muscle there?
Ankle joint has got eversion. Eversion occurs where? Don't confuse. Ankle joint has two movement. Eversion and inversion occurs in which joint? Ankle joint has got plantar flexion, dorsiflexion.
That is the
Inversion occurs in mid-tarsal joint.
Mid-tarsal joint.
Yes, ma'am.
Okay.
So these muscles are
how can you
leading
make
to
tibialis
what?
anterior taut?
Movement of again the movement of the ankle
Tibialis
joint.
anterior, tibial anterior is responsible for dorsiflexion of the ankle.
Yes, sir.
So you ask the patient to
Dorsiflex.
take the ankle up against resistance.
Yes, sir.
So any
And
fixity
others
to
are extensors. Yeah.
So any fixity to muscle, wherever, not only necessarily in the limb, it has to be done in two stages. First is with the muscle relaxed, you should check for movement in both axes. And then after making that muscle taut, you should recheck the movement to see whether there is any diminution or restriction of movement. So it's
Why
not
it is required? Why this relaxed state movement has to be seen? What is the rationality?
Sir, to see it is a.
Why do you need to move the swelling before the muscle is getting contracted?
So to see that it is beyond the muscle, it's lying fixed to the bone or not.
Suppose I say a situation, you want to move the swelling with the muscle relaxed, it is fixed, no movement at all. What is your inference? You cannot move the swelling with the muscle relaxed. Will you contract the muscle now?
No, sir. It means it's already fixed to the underlying structure. There is no need
What underlying structure? In your case, what will be the underlying structure?
Bone.
Exactly.
Bone.
So if it is already fixed without
that
movement,
is the rationality.
Yes.
You move the swelling with the muscle being relaxed to assess whether the swelling is fixed to the bone or not. Fixed to the bone means it has gone through the muscle and then to the bone. So it is fixed as such with muscle relaxed. Don't ask the patient to contract the muscle because already it is fixed.
Yes,
the inference is the swelling is fixed to the underlying bone.
Yes, sir.
Okay.
No pulsations. That means no
skin over the swelling
pulsations.
is normal. You have to say that.
Yes,
you
sir.
can pinch the skin. You can pinch the skin from the swelling.
Yes, sir.
So overlying skin is free.
Yes.
When you say no pulsations, what are you saying? The pulsations over the muscle, over the swelling, right?
Yes, ma'am.
So mention that. If you say no pulsations, because your next line is, I think, about the pulses. So no pulsations over the swelling.
Yes, ma'am. Yes, ma'am.
Okay. Yeah.
Yes.
And then distal pulses are normal. What if you could not palpate? You have to again compare the pulses with the opposite limb.
Opposite limb. Yes, ma'am.
Right. So if a distal pulsation is feeble or weak, what will you infer?
Means it has involved the vascular bundle of that.
So it not necessarily infiltrate. It could also be encasing the vessels.
Or compressing the vessel.
Yeah,
Yes.
compressing the vessels. And this is a condition where, again, the temperature of the limb distal to the growth as compared to the temperature of the upper limb has to be considered, because you might get a relatively cooler limb if the vascularity is compromised. Okay?
Yes, ma'am.
Okay. Please continue. Inguinal lymph nodes were not palpable. So you mean to say that these swellings, that is these soft tissue sarcomas, usually present metastasized by the lymphatic route, or what are the routes of spread of these lesions?
Mostly they are hematogenous route, ma'am.
And anything else? In your history, you took a lot of history about jaundice and pain abdomen. So if they only spread by metastasized by lymphatic route, that history would not have been relevant, isn't it?
Yes, ma'am.
So they do spread by lymphatic as well as hematogenous routes.
Hematogenous. Yes, ma'am.
Okay. Please continue.
So on systemic examination was essentially with a normal limit. And so a case summary. So a 54-year-old gentleman resident of Chakadapur presented with swelling in the left leg in the upper one-third of the lateral aspect of left leg. Initially small, reaching the apparent size of 10 into 7 centimeters in the last 1 month. With complaint of pain in the swelling for last 3 months, there is no associated skin changes of the swelling, and there is no weakness of the lymph or lymphedema distal to the swelling. On physical examination, general survey was essentially within normal limit. On local examination, 10 into 7 centimeters swelling in the left leg in the upper one-third of the lateral aspect of left leg. The swelling was firm, non-tender, irregular in shape, with well-defined margins and fixed to the underlying muscle. There was no regional or generalized lymphadenopathy with normal systemic examination.
You said not fixed. You're not saying fixed to the underlying muscle?
Yes, sir.
In your examination, you said it was, you did not mention about, just go back. Was it? Yeah, it was fixed to underlying structure. Fixed to underlying muscle. Two more points, Perul, I would like to bring about. When you're examining the swelling, you had not mentioned anything about a compressibility of the swelling. You can also have a vascular swelling. We are assuming it is a soft tissue sarcoma, but you must remember that if it is a vascular swelling, so compressibility of the swelling, that has to be mentioned. Second is you talked about lymphedema. Why did you talk about lymphedema? There is no evidence of lymphedema, you have said. Instead of lymphedema, it will be better to say there is no edema in the limb distal. Right.
Yes, ma'am. Yes, ma'am.
So that edema is because of the compression, maybe compromised venous return. So these are the things. But again, you have to remember a swelling in the lateral part of the leg is unlikely to cause a compromise in the venous return. So don't say lymphedema, it is edema in the distal part of the limb with a swelling in your lateral aspect. Okay?
Yes, ma'am.
Yeah. So what is your provisional diagnosis at this moment?
So a 45-year-old gentleman with soft swelling in the left leg, it's most probably a case of a soft tissue tumor, likely a sarcoma. Okay.
So how would you like to confirm this diagnosis?
I will first confirm the diagnosis by doing a radiological investigation like MRI. MRI of the limb has to be done. After that, we can do histological diagnosis by true cut biopsy or coordinated biopsy.
So again, your answer should be that I would like to confirm my diagnosis using certain radiological and pathological investigations. I would like to stage my disease because here you're thinking that probably it is malignant from your history, right? And I would like to prepare my patient for further management. So 3 arms in your investigations. Now, the first arm you said is an MRI. So when you write your MRI requisition, what are you going to write in your requisition for this patient?
MRI left lower limb.
Left?
Lower limb.
So lower limb, exactly. So the point is that don't just write MRI leg. It has to encase one joint above, one joint below, as we said. And also because we will be like to look at the groin to see whether there are any draining lymph nodes. So that
Yes, ma'am.
also has to be kept in mind. Now,
Yes,
when you look at your MRI plates, what
Yes,
are the points that you are looking for?
there's involvement of bone present or not. There was
Start from the basics. That what is the site size of the
tumor.
mass, right? The
Yes, ma'am.
mass as such. Okay. So start again. What are the things you
You
would
have
like to
clinically
look for?
assessed. You have
Yeah.
clinically assessed the size. So the imaging may vary.
Now I'll
You have done the clinical assessment. Can the imaging give you a different dimension?
yes, sir, imaging can give different dimension because by clinical
So
examination
first of
we'll
all, you comment about the tumor itself. What
Yes,
are the important features in MRI in a patient of soft tissue sarcoma? What are these appearance like?
we have to look for the size, shape of the tumor, and there is any surface of the tumor has to be also seen. There is a not margins that is regular or speculated margins are present or not present, and also after that we have to look for the in the sagittal view that there is any necrosis of the patient or there is any hemorrhage inside the tumor.
Necrosis of the tumor.
Tumor.
Tumor necrosis.
Yes, a tumor necrosis, and there is any hemorrhage present or the tumor is cystic inside or not.
So what you
And-
forgot, what
And
is the relation
to
of
the
the
local
tumor with the
structures?
adjacent structures?
yes, ma'am. Yes, ma'am.
Yeah. So again, the site, the size, what is its relation with the muscles? Meaning, is it below a muscle? Is it intramuscular? Is it in the subcutaneous plane above the muscle? Has it involved the surrounding? Meaning it could infiltrate the muscle, it could go right up to the bone. Relation of the swelling with prominent vascular, neurovascular structures in the vicinity. What is the distance between the mass and the vessel? This is going to be very important to plan your surgical excision also. Is it a few millimeters away? Is it a centimeter away? Because you have to plan your excision margin accordingly. And if it is infiltrating it, what is the status of it proximally and distally?
Yes, ma'am.
Again, as you correctly said, whether there is any hemorrhage, necrosis, cystic changes, these are usually heterogeneous masses. And heterogeneity will be more because of the intratumoral changes, that is hemorrhage, necrosis, cystic, etc. Okay,
Yes, ma'am.
right.
Yes, ma'am.
So and also you will also look whether there are any enlarged lymph nodes in the groin or not. Right. What about your tissue diagnosis? What is the ideal tissue diagnosis?
And we have to go for USG guided through-cut biopsy, corneal biopsy from the tumor.
Core-needle biopsy. Okay. Now, suppose you do not have a facility for a core-needle biopsy. Okay. Or your core-needle biopsy done twice has come inconclusive. What will be your next point? Next method of doing a tissue diagnosis?
I can go for an incisional biopsy.
You can do an incisional biopsy. And what are the things that you have to keep in mind? See, because we all grew up doing incisional biopsies for soft tissue sarcomas because in our student days, a core needle gun was not always available. So if you are working in a same place where a core needle is not available and you have to do an incisional biopsy, what are the things that you have to keep in mind when you're doing an incisional biopsy? What are the points that you have to keep in mind?
The incision should be vertical and it should be at the most prominent region of the tumor. And after doing incision, the flap should not be raised. And also,
you should mention another thing.
About
incision
the
should be
incision,
such that it gets excised with the subsequent.
Yes, subsequent
definitive surgery.
Definitive surgery.
Okay.
Yes.
Why do we not raise flaps? You said I will not raise flaps. Why do we not raise flaps?
Yes, ma'am.
You said you are not going to raise flaps. That's what you said, right?
Yes, ma'am.
Yeah. So why do we not raise flaps? Generally for any excision.
Ma'am, to prevent seedling of the tumor to the under.
Yes, we do not want to disturb the, so we want to go make an incision and go right down up to the tumor and take a thing out. We do not want any planes to be violated before the definitive surgery. Okay. Yes. Number 3. So incision, no flaps. Number 3.
Good hemostasis has to be achieved.
again for the same reason. If there is bleeding, with the blood, the tumor cells may also spread. So good hemostasis has to be achieved. Anything else? Anything else?
Hello, ma'am. You're not audible, ma'am.
Anything else? Anything else?
Yes. What other precaution you should take?
So that's about all. So the incision planning is very important. It has to be incorporated in the definitive surgery scar. You do not raise flaps. You go straight down to the mass instead of going layer by layer. Achieve perfect hemostasis and come out. It has to be a minimalistic approach with a good chunk of tissue.
Yes,
Okay.
What about use of diathermy? Diathermy?
What about diathermy? Yeah.
Yes, ma'am.
Diathermy.
Diathermy can be used because it will help in
No, it should be used with caution. No, you should not use liberal diathermy, which can damage.
See, the point is the tissue that you're taking out. If you use too much of electrocautery, the tissue might get
pathological diagnosis will be difficult.
Yeah, so so you will use diathermy. It's not that you won't, but use it with caution so that the chunk of tissue that you take out don't get charged.
Okay, so the report came back as a spindle cell tumor. Spindle cell tumor.
Any role
No
of excisional biopsy? Any role of excisional biopsy?
If the tumor is small, then we can do excisional biopsy, but later on, if it comes to be a case of soft tissue sarcoma, then we have to again go for a definitive wide local excision of that area.
Exactly. So it is better not to.
Yes.
It is better not to. You do a core needle. That is the best option. If for any reason it is not feasible or it is coming inconclusive, then you do an incisional biopsy and then move for the definitive surgery. Right. So you have done an MRI. You have done a tissue diagnosis. Any other imaging you think necessary?
Yes, ma'am. We have to do a CT scan of the abdomen and CT scan of the chest to look for the metastatic workup. And there is any other soft tissue sarcoma in the abdomen present or not.
So do you commonly find soft tissue sarcomas in the abdomen and the limb coexisting?
No, ma'am. Usually they are not.
Exactly. So when you said you're going to do a CT abdomen and thorax, it is more to look for any metastatic disease than for anything else. Now, let's say you have a very small lesion, a 1 centimeter lesion in the thigh.
Yes, ma'am.
And you have done a core needle and they've said it's a grade 1 lesion. Is it necessary to do a metastatic workup for all patients?
No, ma'am. If it's already in the stage 1, then we don't need to do that.
So which are the patients where you will do a metastatic workup?
Ma'am, in patients in which there is history like there is a recent increase in the size of the tumor very much, and with the very big tumors like more than 10 centimeter or more than 15 centimeter, and with patients having complaint of hemoptysis, cough is present or not.
If you go by staging, it is stage 2 and stage 3 tumor should be investigated.
Yes, ma'am.
And you said you had two-cut biopsy. In two-cut biopsy, apart from the tumor histology, they also look for grading of the tumor.
Yes, sir.
How do you grade soft tissue sarcomas? There are 3 criteria to decide about the grading.
Sir, there occurs in the histopathological examination, we have to look for the differentiation of the tumor.
How much score is given for differentiation?
2 or 3. 2 to 3.
Score
of 3, sir. 3, sir. 3, sir. Score of 3.
1 to 3.
Yes, sir. Score of 3.
Differentiated is 1, moderately differentiated is 2, and poorly differentiated high-grade tumor is grade 3. Right. But what are the things, sir, asked that you check for when you do a grading?
The
differentiation. Second?
Necrosis is present or not, and other is...
What is the grade? For necrosis, grade is what?
2, sir. 2.
No.
0.
0, 1, yes. 0, 1.
2. Yes, 0, 2. And necrosis is differentiation and mitotic grade.
Mitotic figures.
Yes, sir.
How do you grade that mitotic figures? 1 is what?
It is 3, sir. It is 1, 2, and 3.
1 means how many mitotic figures? Part 10 high power field?
Less than 10, sir. Less than 10.
Less than 10. 0 to 9.
Yes, sir. 0 to 9. is road 9. Yes.
And also abundant stroma, the stromal component, that will also help you in your grading.
Yes, ma'am.
So if you have T2, to you have said 10-15 centimeter. Mind you, T2 is above 5 centimeter. So soft tissue lesions above 5 centimeter with grade 2 and 3. These are the patients where you will have to do a metastatic workup. And
Yes, ma'am.
otherwise, if a patient has history or clinical examination suggestive of distant metastasis, whatever be the size of the tumor, you will go for a metastatic workup.
Metastatic workup.
Right. Okay.
Yes,
How
ma'am.
will you like to manage this patient?
By doing a wide local excision of that tumor, use with a healthy margin of 1 to 2 centimeter.
1 to 2 centimeter. Now, in the limb, sometimes it is very easy if it is far away from the neurovascular bundles. But if it is in close proximity to the neurovascular bundles, getting a margin of 1 to 2 centimeter can be challenging. So what do you do then?
So in this patient, you see, it's a 10 centimeter tumor, you say, in the lateral compartment. Almost it will be occupying the whole of lateral compartment.
Yes, sir.
So the idea of doing a 2 cm wide excision will
Yes,
entail what? Here, our idea is to conserve limb.
Preserve the limb. Yes, sir.
Margin all around. What do you
Yes.
think? What will happen to the lateral compartment muscle?
That has to be excised, sir.
So it will
So
be like total excision of the compartment.
Yes,
Isn't
sir.
it?
Yes, sir.
Then,
Yes.
then he will have deformity. If
Then
you
we
need
have
to
to-
excise so much of this, which
Yes,
is
sir.
such a large swelling, is there an alternative option?
We can go to we can start neoadjuvant chemotherapy for these cases so that the tumor size can be decreased before operating the patient.
So there are some indications. You see, a tumor of 5 centimeter, you not give the patient neoadjuvant therapy. If you can do a good wide excision without compromising the limb function.
Yes, sir.
If the tumor is 10 centimeter or you say the tumor is fixed to the muscle,
Yes, sir.
in that case, there is a role for giving neoadjuvant what? Neoadjuvant what you give?
Chemotherapy, sir. Chemotherapy.
Huh?
Chemotherapy, sir.
Only,
Hello, sir.
only chemotherapy for sarcomas?
No, and
Sarcoma?
neoadjuvant chemotherapy and radiotherapy, both, sir.
What is the idea? What is the idea of giving this neoadjuvant treatment in this patient, which has got a 10 centimeter tumor fixed to the underlying muscle?
To make
How is going to help you?
To make it resectable and to preserve the neurovascular bundles. If in
Neurovascular are not involved. Clinically, you say there is no involvement in neurovascular bundle.
Yes,
The
sir.
point is, this is a large tumor involving almost the whole of the lateral compartment.
Yes, sir.
And if you take 2 cm wide, it will go to the more extensive areas.
Yes, sir. So they
Idea is
to prevent the limb deformity, sir.
It is more for limb preservation that
Yes,
we are
sir.
doing the neoadjuvant therapy.
Yes,
First is limb preservation. Even after that, if there is not good response, then what sir said, that if you excise the whole of the lateral compartment of the muscles, then there is bound to be
reconstruction has to be done.
limb deformity and certain sort of muscular replacement. Yeah,
Yes.
that need to be done, that you take a muscle from another compartment and do a switching into this compartment to take over the function.
Yes, ma'am.
Is there an option of an amputation in such a patient? The one sir is saying is a huge mass, not responding to neoadjuvant therapy. Is there any role of amputation?
or in broad sense, indication for amputation in soft tissue sarcoma in the limb. What are the indications? Earlier, it was more frequently used. Before the advent of good radiation chemotherapy, the standard of care was doing an amputation. So, as on today, limb conservation. But
Yes,
there are some situations where you can consider doing a amputation.
Sir, if in this case after doing surgery there is severe deformity and if we in this case if we do the amputation and a good process is available, so we can go for amputation of that limb.
This deformity can be corrected by plastic surgeon. If you have a deformity and that deformity corrected by the plastic surgeon by tendon transfer, it's not an indication for amputation. There are some situations. Is bone involvement always an indication for amputation?
Yes, sir.
Or still there is a hope for limb conservation?
In today, are there any methods of tackling bone involvement.
Ma'am, yes, ma'am. We can do after means after doing the taking out that involved part, we can do the reconstruction part from the.
If bone is involved, if the bone, the answer should be if the bone is involved, there is still a role for limb conservation.
Yes,
In that case, you have to give the patient neoadjuvant chemoradiation
yes, sir.
and then reassess.
Yes,
You
sir.
can do a resection of the bone and you can do even bone grafting.
Bone grafting, yes, sir.
There is a third
Okay.
method where you can do resection of the bone, irradiate the bone, and then refixation of the bone. So that is also a newer development where if you see that the bone is, you take it out
Yes,
and
ma'am.
in real time, you irradiate the bone, shift the piece of bone to the radiation department, they irradiate the bone, you bring it back and you refix it. So if it is a small gap, it can be replaced by bone grafts. But if
Yes,
it is
ma'am.
a larger chunk, particularly in the thigh region, that is the femur, there is a
Yes.
chance of irradiating the bone and refixing the bone with muscle refixation. Okay. So
one indication of
amputation,
amputation will be when the limb will be functionless. You are
functionless.
doing a
Functional.
resection and
Yes,
then
sir.
limb become non-functional. That is the situation you can consider doing amputation.
Yes, sir.
And recurrent tumors. When
Yes,
there
sir.
is a recurrent tumor, you can go for a second excision. It's a recurrent tumor, large tumors. In that case, there is a role for doing a amputation.
Yes, sir. Yes.
Now, let's say the mass was not so big, but it
Yes.
is in close proximity to the neurovascular bundle. So what precautions do you have to take when you're excising the mass?
Sir, ma'am, the perineurium has to be removed and the adventitia of the vessel has to be removed along with the tumor.
Right.
Yeah.
So you have to take caution to take out the perineurium and the vascular adventitia. But you have to remember there is going to be an element of neuropraxia post-surgery in these patients. So there is going to be some weakness of the limbs, which is going to take long to recover. So in addition to your adjuvant therapy, physiotherapy, and other neural supportive therapy has to continue for these patients.
Yes, ma'am.
Okay. Now,
Yes.
let's say that this patient has evidence of distant metastasis.
Yes, ma'am.
What will be your plan for this patient?
Neoadjuvant chemotherapy
Yes.
and radiotherapy for this patient. After that, we have to again stage the disease. And after that, definitive surgery can be done. If it's already in the metastasis to lungs or any other area, then palliative chemotherapy has to be given.
Yeah. So every metastasis now they divided into two groups, something called oligometastasis and the other is florid metastasis.
Yes,
So
ma'am.
in case of oligometastasis, there is some role of therapy for the oligometastasis. But if it is widespread metastasis, yes, you will give systemic therapy, but it may be of a palliative intent.
Yes, ma'am.
Okay. Sir was talking about recurrent tumors where we might have to ampute a patient. So if a soft tissue tumor just does recur, what are the types of recurrence that you can have?
Local recurrence can be there with
Okay.
and isolated distant metastasis can also be possible.
Yes.
Yes.
And widespread metastasis. So this
Yes,
is
yes.
just what I touched upon. So if
Yes,
it is isolated metastasis, again, we go more aggressive. If it is a widespread metastasis, is more of a palliative intent. Now, if there is a isolated local recurrence, how do you manage that?
we have to treat that case to be a new case of soft tissue sarcoma.
Yes. So you would treat it like you remember in your history, you had said no scars. So
Yes,
you had
ma'am.
said that probably if it has been operated before. So you will treat it with the same algorithm as you would a primary tumor.
Yes,
So
ma'am.
patient has been operated, has received the neoadjuvant therapy. What is going to be your follow-up protocol of this patient?
We have to follow it for 3.
Before follow-up.
Yes,
What
sir.
is the change in AJCC 8th edition for soft tissue sarcomas? There are some changes in the AJCC 8th edition. What are the changes?
So now T4A and T4B is there and
Before that, earlier it was taken as T1, T2,
T2,
superficial
T3.
and deep.
Yes,
Now
sir.
this superficial and deep part is not there in the 8th edition.
Yes,
It's
sir.
by tumor size up to
Yes,
T4
sir.
and
Yes,
then
sir.
involvement of the cortical bones
Yes, sir.
and the skull base if it is in the head and neck.
Yes,
Okay.
sir.
And
Yes,
then they have added the grade as part of
of the ADCC. Yes, sir.
staging.
Yes, sir.
Okay. The grade also dictates the staging. So these are
Yeah.
the two changes in 8th edition. Okay, Madam was asking about the follow-up. How do you follow this patient up? You have done a wide excision. And
Yes.
what is the indication for adjuvant therapy in this patient? This patient underwent excision upfront.
Yes, sir.
And then what is the subsequent treatment? Patient goes home on follow-up, or he needs to do something else?
Now, if the resection margin is positive, then we have to give a,
Negative margin.
and if negative margin but close
Negative
margin.
margin.
Yes, sir. If it's
Negative margin, clear.
then we
Keep in mind,
then,
this is a 10 centimeter tumor.
yes,
Even
sir.
with a negative margin,
Then we have
tumor
to
which
give
is
chemotherapy
T2,
also.
T3 will require
Chemotherapy, sir.
not
Yes, sir.
chemotherapy.
Hysterectomy.
No,
Chemo and radiotherapy. Sorry, sir. Radiotherapy.
local
Radiotherapy.
radiotherapy.
Yes, sir. Local radiotherapy in the form of brachytherapy. Yes, sir. Or external beam radiotherapy. Yes, sir.
Is
So
there
that will
any
depend on
role
the
of
staging.
Yes, sir.
is there any role of intraoperative radiotherapy in these large soft tissue sarcomas?
Yes, ma'am. There is a role because
So
Or
what
if
is
I ask
done
you a
is
question, what are the different forms of radiotherapy you can administer for soft tissue sarcomas?
brachytherapy, external beam radiotherapy, and yes,
And
sir.
you said brachytherapy. And now there is another advancement.
intensity
IMRT.
modulated radiotherapy.
Yes, ma'am.
IMRT. Yeah.
How will you give brachytherapy in this patient? This is now given. In good centers,
Yes, sir.
they administer brachytherapy because brachytherapy has a number of advantages. It's a short duration.
Yes, sir.
The side effects are much less. The lateral tissue damage is much less.
Yes, sir.
How are the brachytherapy administered? Who administered this?
Surgeon, sir.
Surgeons. Surgeon put something.
So that is what I say.
Surgeon put
Intraoperatively, what
catheters,
do they
sir.
do? Yeah,
Sir,
Huh?
surgeon
needles.
puts a number of needles or catheters at the in the tumor
Yes.
in the tumor bed,
Yes.
and later on they give radioactive materials, radioactive wires in that
Yes.
catheter.
So while doing surgery, you can put some wires
Catheter.
through
Yes,
which the radioactive material can be placed by the radiotherapist.
Yes, sir.
So that is the principle of brachytherapy.
So it is a
And what
high
is the advantage of
intensity local radiotherapy. So you're getting a
Yes.
boost right into the cavity. So these needles and wires are placed after excision of the mass, and the cavity that is created, you keep the needles there and you close the wound. And subsequently, your radiotherapy colleagues, they give radiotherapy to that through the wires and needles that you have placed.
If you're not
Yes.
giving brachytherapy, after excision, what should you do? After excision the tumor, what you should do in the bed?
If we cannot
You
prove
have to mark.
Mark.
You have to mark the bed by applying few clips in the periphery, because
Yes, sir.
that is the area that radiotherapist will find on imaging that this area where the tumor was. So he has to give a
radiotherapy at that area.
radiotherapy at the tumor bed.
Tumor
itself.
bed marking. Yeah, that is what we look for.
Yes, sir.
Okay, so coming back
Follow-up?
to the
Follow-up
follow-up.
protocol? Follow-up protocol?
We have to follow up every 3 monthly for first 2 years, and after that we have to follow up for every 6 monthly for next 2 years.
Why more intensive follow-up for initial 2 years? Why
There's-
more intensive follow-up for next initial 2 years?
There's a high chance of recurrence.
Yes.
Yes,
Most of the
local
recurrence.
Yes, sir.
They
Local
occurs within
recurrence
2 years.
almost 60 to 70% recurrence occur in initial 2 years of time. So the intensive follow-up.
Yes, sir.
How do you follow this patient up? On follow-up, patient has came to you. What's your job to do?
We have to do for clinical examinations. Chest
Yes.
X-ray has to be done.
X-ray of what?
X-ray of chest X-ray, sir. Chest X-ray to look for any lung metastasis, and X-ray of that limb has also been done. CT or MRI can also be done of that limb.
Every 3 months CT MRI?
Every 6 months we should be done.
Depends. If it is a tumor quite at a depth,
Yes, sir.
you have done a reconstruction using a flap, you cannot do a proper clinical assessment. That is the time where you should go for imaging.
MRI.
Otherwise, with a surface tumor, you can assess by clinical examination.
Yes, sir.
Okay.
Yes, sir.
Okay,
Okay.
9 o'clock.
Nine
Just
o'clock.
gone 1 hour.
Okay,
Okay.
Behrul. I think
Yeah.
he presented quite well.
Yeah, yeah.
Yes.
He was sick yesterday, so I shifted the class.
I know. I
Yes, sir.
understand.
Yes, yes.
Okay.
Okay.
Thank you, Behrul. Thank you.
Thank you.
Thank you, sir.
Behrul. Thank
Thank
you,
you.
sir.
Okay.